Hello once again, and welcome to the Puscast, a review of the infectious disease literature with snarky commentary. For the last 2 weeks of February, there's an R in that month, 2009. Remember, if you're sick of this intro, you can skip ahead to the next chapter. This is available on iTunes, where my fragile ego demands you write glowing reviews. This is brought to you by Pusware LLC, the publisher of the Persiflager's annotated compendium of infectious disease facts, Dogma and Opinion, your uber hyperlinked electronic guide to infectious diseases at Pusware.com. All the opinions are those of Mark Crislip, MD, and Pusware LLC, and nobody else who knows a burrow from a burrow. Now CME accredited. Listen, take the online quiz, get a half an hour of free CME, thanks to Legacy Health System. Also, because this is CME accredited, I have to mention my potential conflicts of interests. I ain't got none, so that's simple enough. The purpose of this podcast is to review the infectious disease literature of the last 2 weeks, and with commentary to claim and pontificate on those articles that are of interest to me. As a warning, it is not called Persiflagers for nothing. This podcast will contain snide comments, sarcastic asides, and short rants. Don't complain I didn't warn you. I always operate on the assumption that the world needs more Mark Crislip, so listen to my Quackcast, a review of supplements, complementary and alternative medicine, i.e. scams. I'm an occasional blogger on the Science-Based Medicine blog. I have my own infectious disease blog at Rubor, Kalor, Tumor, and I now Twitter at KnowItAll is my handle. I don't think they call it a handle on Twitter. Now, on to the literature. We have talked about mannose-binding lectin before, mannose-binding lectin, or MBL, major B glace ball. This is a protein made by the liver that binds to bacteria and optimizes phagocytosis and the complement pathway. And we've talked about studies that have shown patients who have a deficiency in mannose-binding lectin due to polymorphisms have an increased risk of infection. Now, guess what happens when you take a liver which is deficient in mannose-binding lectin production, and you transplant it into somebody? Those patients get a 3-fold greater likelihood of developing an infection. So as you drink yourself into that cirrhotic stupor, just remember when you get your transplant, you want to get a liver that makes enough mannose-binding lectin. Now what they have is recombinant mannose-binding lectin, and they're now involved in a study in liver transplant patients, giving them infusions of mannose-binding lectin to try and prevent infections. A very promising therapeutic intervention in these patients, and again, a nice biologic study. There are 2 rules in medicine. One, every disease gets treated with steroids at some point. The other is every viral disease receives at some point ribavirin. How about Japanese encephalitis? Well, in a randomized, blinded, controlled trial of oral ribavirin in patients with Japanese encephalitis, there was no benefit. Ribavirin does not work for Japanese encephalitis. At my hospitals, thanks to aggressive implementation of hand hygiene and bundles, hospital infections have plummeted to almost 0, which is very depressing because that's how I make my living. Thank goodness for anti-TNF antibody inhibitors and Infectious Disease Employment Act. Not only do they cause tuberculosis and reactivation of endemic fungi, but it looks like they're associated with the reactivation of herpes zoster, i.e. shingles. In this study they published in JAMA, they looked at the association of TNF inhibitors and viral infections, and they found that the zoster incidence was 11 per 1,000 patient years in those who got monoclonal antibodies, 8.9 per 1,000 patient years in them what got etanercept, and 5.6 per 1,000 patient years for those who got more mundane DMARDs for their rheumatoid disease. So yet another reactivation disease associated with anti-TNF antibodies. In the United States now, there have been 1 million cases of AIDS, about half of which have died. And there are about 500,000 Americans now living with AIDS. Now, the interesting thing is the breakdown. Women now account for about a quarter of AIDS. And blacks, while accounting for 13% of the population, account for 50% of patients living with AIDS. But another curiosity about HIV disease is that 40% of people living with AIDS reside in the South, to quote the report, 29% in the Northeast, 20% in the West, and 11% in the Midwest. I just find it curious that the highest percentage of people living with HIV reside in what's commonly referred to as the Bible Belt. I'll let you draw your own conclusions from that. But what's really depressing about this million AIDS cases is how many of them would be preventable with simple things like condoms and needle exchanges. I wonder how many of those deaths are needless. It's always been a big question what to do with acute HIV, to treat or not to treat. This study was presented at the AIDS meetings in Quebec, or should I say Quebec, from Dutchland, where they randomized patients with acute HIV to either get 6 months or 15 months of HAART with their acute HIV disease. If they got treated with HAART for their acute disease, they delayed the progression of disease by about a year. Now, this was a small study, only 102 patients, but it's certainly intriguing, and one would really wonder, at least I still wonder, if patients should be put on antiretrovirals whenever you diagnose them. The higher the CD4 counts, the better patients tolerate the medications, but there's issues of long-term toxicity and the breeding of resistance. But I still wonder if someday the treatment of HIV disease is going to be the day you diagnose them is the day you treat them. It would turn out that what you think is true, that a meta-analysis of adherence of antiretroviral therapy shows that those that have once daily dosing do better than BID dosing. And while that's not a surprise, often what you think is true may or may not be true when tested. You know the old saying, don't believe everything you think. Now, this is a meta-analysis of multiple HIV trials, and the problem with meta-analyses is that a meta-analysis of meta-analyses showed that meta-analyses are only 50-50 at predicting what will happen in a real trial. Be that as it may, once daily is probably better than BID and is certainly better than TID. I can't even remember to take once-a-day drugs. I remain thankful that the Thorazine is a once-a-month depot injection. Sometimes it's just the title of the reference that draws your attention. I've unfortunately had a number of funerals to attend of late, and they've all been somber affairs in churches. The title of this article is Disco Funerals, a risk situation for HIV infection among youth in Kenya. It turns out in Kenya there's a disco funeral where everybody gathers for several days with music and dancing. And unfortunately, lots of sex and the transmission of HIV. But when I die, I want a disco funeral, okay? None of this somber ashes to ashes, dust to dust crap I've had to listen to of late. I want people to party like it's 1999 when I die. And they probably will, come think of it. But what the world needs is more disco funerals. If you haven't noticed while I'm doing this podcast, I'm sick. I've been sick for 3 days now, with fevers to 102, myalgias, minimal cough, however. I was thinking maybe I had an attenuated course of influenza because the vaccine, which I always get, is again not covering all the strains circulating. There are two kinds of influenza B out there. There's the Victoria lineage and the Yamagata lineage. Last year they put in the Victoria lineage and it was all Yamagata. This year they put in Yamagata and it's now all Victoria. So there's yet another mismatch in the vaccine. And we are having a peak in flu activity in Oregon and the United States this week. Am I one of those victims? I'm not a victim. One of those patients with the flu? I don't know. I'm not coughing that much, but I don't feel real good. So we'll see. If I seem to be foggier and more off base than usual, we'll blame the interferon storm, although my brain is surprisingly clear today, unlike the last several days. Can you tell? There are two extremely efficient ways of spreading infection: sex and cough. God knows what would happen if you coughed while having sex. Anyway, this study looked at airborne influenza particles in a hospital emergency department. And they found influenza particles by PCR floating in the air at a size that you could inhale to cause disease. To quote the abstract, our results provide evidence that influenza virus may spread through the airborne route. Big duh there, dude. The other thing which this study emphasizes is that, like every other hospital I know, they do a horseshit job in ER of putting masks on patient with a coughing illness. I've said this before, but the reason you have your patient turn their head and cough when you're checking for a hernia is not that it brings out the hernia, it's so they don't cough on you. If someone's coughing, you should have them wear a mask. Or you should wear a mask when you go in the room. Most people don't do that. They should. Cough is an extremely efficient way of spreading infectious diseases, be it in the ER or your house or during sex. When it comes to resistance to antivirals, I always say antiretrovirals. If I say that, please excuse me. For influenza, not all strains are the same. It turns out that the H1N1 influenza A virus more easily becomes resistant to oseltamivir than other strains of influenza A, and influenza B is not as likely to become resistant. It's a single-point substitution of histidine to tyrosine at position 274, for those of you who are taking notes, that confers resistance of influenza A to oseltamivir, and the H1N1 seems to do that much more easily than other strains of the virus. Hopefully the bird flu is less prone to getting resistance. There has been a suggestion that perhaps the HPV vaccine is associated with Guillain-Barré, like my French accent there. My oldest has just left for France for 2.5 weeks. I wish I was my son. So they went back and they looked at all the data trying to see if there's a relationship between getting the Gardasil vaccine and the development of Guillain-Barré. And unfortunately, they couldn't say one way or the other. They found, in looking at all the cases, that the risk of getting post-vaccination Guillain-Barré was about 7 cases per million patients. And it's estimated that the syndrome in the general population is between 4 and 10 cases per million patients. So if there's a relationship between the vaccine and Guillain-Barré, it's about at the rate that the disease normally occurs. Thanks to pap smears, the rates of death from cervical cancer have declined. Still, 11,000 women get cervical cancer every year and 4,000 die of cervical cancer every year. Contrast that to the 36 cases of Guillain-Barré last year. It's a tough call, and certainly whether or not it causes it is still up in the air. I also like this quote from the Medscape article, that the association between the vaccine and Guillain-Barré has caught the attention of, quote, physicians, the CDC, government watchdog groups, and malpractice attorneys. I'm sure it has. Warning, I'm not a pediatrician, although I act like a child, but I found this article interesting, so I will mention it. It's that using a probiotic to treat kids with secretory otitis media. So it turns out that kids who get more otitis have fewer normal flora and increased number of bacterial pathogens in their nasal pharynx. So the reasoning goes, if we reinstitute normal flora, will you decrease the number of infections these kids get? So these kids are randomized to get either strep sanguis, lactobacillus rhamnosus, or placebo squirted up their nose twice a day for 10 days. And then what got the streptococcus sanguis had a marked decrease in their infection rates compared to those that got the lactobacillus and those that got placebo. Now, there were only about 17 or 18 kids in each group, so this is not what you call a huge definitive trial, but I find it interesting nonetheless. I'm sure the Dannon yogurt people will soon have you squirt their yogurt up their nose to prevent infections. So there's always the issue of cranberries, juices, and urinary tract infection. This study looked at cranberries or trimethoprim for the prevention of UTIs in older women. They took a bunch of women that had had multiple UTIs in the last year, and they randomized them to either get cranberry extract or low-dose trimethoprim, and found no difference in the two groups. They conclude, therefore, that people can use cranberry extract rather than trimethoprim for the prevention of urinary tract infections. Unfortunately, they did not have a placebo wing in this trial to know for sure that that is a good recommendation. The reason they didn't do a placebo wing is they say in their article, well, we didn't include a group of placebo because the Cochrane reviews suggest that cranberry is effective in the prevention of urinary tract infections. Maybe, maybe not. Older people have decreased glomerular filtration rates, and one would wonder if either drug were equal to placebo. Unfortunately, because of a lack of a placebo group, I don't think you can have any good conclusions from this study in this patient population. If memory serves, the first time I talked about URIs and vitamin D levels was a study done in Finnish military recruits. That study has been reproduced in the Archives of Internal Medicine, where they looked at about 18,000 people and their vitamin D levels and found that the lower the vitamin D level, the higher the risk of upper respiratory tract infection. Remember that vitamin D, while important for bones and calcium metabolism, is also a key hormone for immunomodulation for infectious diseases. So here's an example of how vitamin D is involved in the immune system. There's a plasma protein called cathelicidin. Cathelicidin is an antimicrobial and immunomodulatory peptide, and it's regulated by vitamin D. Now, this study looked at dialysis patients and found that if they had low vitamin D levels, they also had low cathelicidin levels, and if they had low cathelicidin levels, they had twofold increased risk of death by infection. Last podcast, we mentioned how vitamin D supplementation did not alter the course of tuberculosis, but it's important that patients be therapeutic in the level of their vitamins, though there is nothing to be added by giving patients supra-therapeutic levels of vitamins. This next study is allegedly a compliance study on pneumonia. They took a bunch of people with presumptive lower respiratory tract infections treated as an outpatient. Their antibiotics were dispensed in bottles that could be monitored for when they were open, and they were given either a once a day, twice a day, or thrice daily antibiotics, and found that the longer the course of antibiotics or the more frequently they had to take the antibiotics, the poorer the compliance, which is no surprise. However, my take on the study is that probably since there was no difference in outcomes, that most of these patients either didn't need antibiotics or everybody with outpatient lower respiratory tract infections only needs a short course of a once-a-day antibiotic. If you're giving someone 10 days of a 3-time-a-day antibiotic, you're probably giving too much too frequently, or you've really misdiagnosed the patient. The good news is that line infections are decreasing in critical care units, according to JAMA, and they're down 50%, which is pretty impressive. Why is that? Probably two reasons. One is evidence-based protocols to optimally take care of central lines. Every place has all these bundles that we're applying to prevent infections, and they're extremely effective. And I think the other is probably the increased use of alcohol foams to prevent infections. Every time our foam rate goes up, our infections drop. It's much better than hand washing. And if you don't foam your hands with alcohol before and after every patient contact, you're a worthless, incompetent bastard who doesn't deserve to practice medicine. Oh, did I say that? Excuse me. Here's an interesting question. Is MRSA intrinsically more virulent, or is it just our antibiotics are ineffective in killing it? It's always been an interesting question. This study looked at the virulence of MRSA in a caterpillar model, the wax moth caterpillar, and they injected the caterpillars with staph and saw how quickly they died off. This evidently correlates well with mammalian models. The interesting thing is, as they used vancomycin intermediate strains of MRSA, the virulence in this model decreased. So apparently, MRSA that are have higher MICs to vancomycin, at least in a caterpillar model, are less virulent than the native strains. This is backed up in clinical studies, or at least clinical reports, where patients who have higher MICs to vancomycin are less likely to have septic shock than those with lower MICs. And one patient with a vancomycin intermediate staph bacteremia had 87 days of bacteremia without acute clinical instability. So it would appear that as your MIC goes from 1 to 2 to 4, the virulence of Staph aureus goes down in humans and in caterpillars. There's been a couple strains reported in the New England Journal of Medicine of quinolone-resistant Neisseria meningitidis type B. There were 2 strains, one in California. This one looked like it was a point mutation to affect the binding site of the quinolone. More interesting is another strain in North Dakota, Minnesota, that looks like it acquired its resistance through horizontal gene transfer from Neisseria lactamica, if that's how it's pronounced, which is interesting. Always remember that bacteria are actually one giant organism, and they can swap genes back and forth with relative ease. Now, there are only 6 cases of quinolone resistance, but quinolones are the mainstay currently of prophylaxis for exposures of patients to Neisseria meningitidis. And if this increases in frequency, we will lose again another one of our antibiotics for the treatment of infections. As an ID doc, it's hard to quibble with people's initial antibiotic choices as long as they kill everything that kills the patient. Often it's what you do after you get the cultures back that makes you look less than knowledgeable about your treatment decisions. But if you don't treat patients appropriately up front, their chance of death doubles. This is shown again in 2 studies, one with Pseudomonas bacteremia, the other with MRSA. Patients who got inappropriate initial antibiotics had 2 times or more risk of dying compared to those that got appropriate antibiotics. Remember, in the ICU and other settings, when you're picking your antibiotics for patients, you're literally betting your patient's life that you know what you're doing. And if you don't, you should probably call your local infectious disease doctor. This message brought to you by the Infectious Disease Society of America. We kill bacteria. And did you know that vancomycin is the only FDA-approved drug for the treatment of C. diff? I didn't know that. That's what this article says. This study compared vancomycin versus nitazoxanide for the treatment of Clostridium difficile. It was a randomized, double-blind study. There weren't a lot of patients in the study. Only 50 patients were randomized to get either vancomycin or nitazoxanide. But it would appear that they are equivalent, at least in this trial. Of course, 50 patients isn't much, but there are other studies to show that nitazoxanide is effective in the treatment of C. difficile diarrhea and is something to consider if you failed vancomycin and metronidazole, which seems to be, as best I can tell, occurring with increasing frequency. And it would appear, at least in this small trial, to be no less toxic than vancomycin. So remember nitazoxanide for the treatment of C. diff once you've used your vancomycin and metronidazole with no effect. This is a meta-analysis that looked at the role of breastfeeding in the prevention of Helicobacter infections. And I did not know this, but being breastfed is protective against subsequent H. pylori infection. This is interesting because in Japan, at least, it appears that the predominant source of Helicobacter in infants is from their mom. But that article did not mention the role of breastfeeding. I want to emphasize, though, the breastfeeding is for newborns, not for adults with Helicobacter infections. I just mentioned this article for hoots and giggles. This is a test tube article where they killed extremely resistant Mycobacterium tuberculosis with a combination of meropenem and clavulanate. In the real world, you probably have to give the patient meropenem and timentin to take care of that infection, but at least there's a potential antibiotic that can be used, at least in countries with lots of resources, which currently is not the United States. So you got a line infection. They always want to salvage the line, don't want to pull it out. Well, if you're a cancer patient with candidemia and you don't pull the line soon, your chance of having a bad outcome, such as, death, goes up. So in the study in question, patients who had their line pulled less than 72 hours after the onset of their candidemia had better outcomes than patients whose line stayed in. You have a patient with candida in their bloodstream, they got a line, pull the damn line. How hard is it? Sometimes bad things can have good unintended consequences. No bad deed ever goes unrewarded, just as no good deed ever goes unpunished. This looked at the rate of MRSA transmission before during and after the SARS epidemic in Toronto. Before the SARS epidemic, they averaged 8.8 cases of hospital-acquired MRSA per 100 admissions. After the SARS epidemic started, it dropped to 3.8. And then everybody had a mandatory infection control, and it dropped to 1.9 cases per 100 admission. During this time, alcohol-based hand rub did not alter, nor did the compliance with hand washing alter. And the number of patients with MRSA was the same. However, awareness and adherence to general infection control procedures took the MRSA acquisition rate from 8.8 down to 1.9, which is pretty good. You know, infection control actually works. If people would just practice it, we would have far fewer infection-related deaths in the hospital. So that ends this interferon-laden Puscast, a review of the infectious disease literature for the last 2 weeks of February. Note the R, 2009. References, including some not mentioned in the podcast, are available on the website. This is CME accredited. Now that you've listened to me in my hoarse, gravelly voice, take the online quiz and get a half an hour of free CME. Thank you, as always, to Legacy Health System. Brought to you by Pusware LLC, the publisher of the Persiflager's Annotated Compendium of Infectious Facts, Dogma, and Opinion, your Uber hyperlinked electronic guide to infectious diseases, available at pusware.com. Don't forget to log on to iTunes and write me a glowing review to feed my ravenous ego, and listen to the Quackcast, read my blogs, and subscribe to my Twitter accounts. The world does indeed need more Mark Crislip. My ego is bigger than Zaphod Beeblebrox. Bandwidth ain't free, so feel free to purchase the compendium and support the podcast. Copyright 2009 with the Creative Commons license. The music is by my son when he was 12 years old, improvising on the guitar. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, goodbye.